Coronavirus disease, or COVID-19, may be abating in some regions of the world, but it is and will affect our personal and professional lives for the foreseeable future. It might be too early to take a step back and look at how to better prepare for the next pandemic, which is sure to come, but we can look at what we can still do today to be of help to our patients as well as our fellow citizens. In this presentation, I will focus on explaining some basic epidemiological concepts, as well as addressing current and emerging information about contagion, transmission, testing, and also provide a list of trustworthy resources. With that in mind, the goals for this presentation are the following. I will try to explain and clarify information and data we hear and read about regarding the COVID pandemic, address relevant concerns as well as help to parse facts from fiction, prepare our healthcare professionals to assist both patients and communities in need of reassurance, but please keep in mind that the science and information about COVID-19 is evolving very rapidly. This presentation, recorded on April 8, 2020, is therefore time sensitive and should be viewed accordingly. So what can we do as oral healthcare professionals? Well, we are and can continue to be a trusted source for health information. We can counter misconceptions and misinformation by separating facts from fictions. We can share personal protective equipment with those who care for affected patients. We can provide appropriate and safe care for our patients. We can be responsive, and we should be responsive to our co-workers' concerns and fears, and that includes, of course, also our patients. And in the future, maybe we can look at different ways of utilizing dental clinics. For example, use it for a site for testing, which obviously is a very important strategy in order to deal with these type of pandemics today and in the future. And lastly, maybe we can actually use dental clinic as a site for mass vaccination. We certainly have the facilities to do it and the expertise, as well as all the personal protective equipment and other equipment needed in order to help to do and to institute these type of strategies as well. So I can see a lot of things going to change in the way we practice dentistry, as well as how we utilize our dental offices, and we'll talk more about that in the last couple of slides in this presentation. But in order for all of us to sort of get on the same page here, what I would like to do is to explain some of the concepts and some of the words being used and here we hear a lot about in this pandemic. And the first thing is, what is an epidemic? The epidemic is the occurrence of more cases of disease than expected in a given area or among a specific group of people over a particular period of time. In this slide here, as you can see, there are some small outbreaks in 3 different states in the United States. I used this as an example, in Washington, in Oregon, and California, but these little outbreaks are contained within those states and are not spread any further. So we can call this an epidemic. On the other hand, if the epidemic occurs over a very wide area, several countries or continents, it's usually affecting a large proportion of the population. We talk about the pandemic. And examples of pandemics in the past are cholera, AIDS, pandemic influenza, SARS, and COVID-19. On March 31st, at the WHO headquarters, the Director General of the World Health Organization declared COVID-19 a pandemic. There are now more than 118,000 cases in 114 countries, and 4,291 people have lost their lives. With that in mind, he then declared this a pandemic, which would then result in different countries have then now the ability to institute certain strategies they couldn't have done before it was declared a pandemic. So March 31st, it was declared a pandemic. What about other glossaries or vocabularies that were used during an epidemic, in this case a pandemic? One thing that we hear a lot about is quarantine. Now, quarantine restricts movements and contacts of an individual without signs and symptoms of the disease. A mass quarantine was what the Chinese authority did in the Hubei province, where they actually quarantined 16 million individuals, meaning they restricted movements and contacts with individuals outside of households and other facilities, so these individuals couldn't be in contact with anyone else. Now, isolation is different than quarantine. Isolation restricts movements and contacts of an individual with signs and symptoms of disease. So quarantine That's when we try to isolate an individual or restrict the movements and contacts of an individual that might be an incubation period of the disease. When it comes to COVID-19, we anticipate that's around 14 days. Isolation is someone with signs or symptoms or have already been diagnosed by some kind of test that they are infected and infectious, and those individuals we isolate. So big difference between quarantine and isolation. Herd immunity, resistance to the spread of a virus due to increased immunity among the population. And we usually talk about herd immunity when we talk about vaccination. How many people need to be vaccinated in order to have very low spread of patients that may still have a disease or the vaccine didn't work. We'll talk about herd immunity, meaning we need to get to a certain level of immunity in the population for these diseases not to continue to spread. Flattening the curve depicts the measures to slow the progression of the epidemic, and I'm going to talk more about that later on. Lockdown and shelter in place, extreme measures to diminish contact between individuals in the population. And social distancing is a strategy where individuals try to have a specific distance between them when they meet with each other in order to mitigate aerosol transmission of the virus. In Europe, usually are looking at 3 feet or 1 meter. In the United States, we are looking at 6 feet or 2 meters. R0 or R0 is the reproduction number of a virus, or the expected number of individuals being infected by an infected individual. For example, if R0 is above 1, it suggests that this one person who is infected can infect at least one other person, which means the infection and the epidemic is continuing. When R0 goes below 1, at that point we talk about that the epidemic is slowing down. Growth rate is a more specific way of looking at the rate of progression of an epidemic, and I will show you a little bit later on how they calculate that. Another thing that we hear a lot about is case fatality rate. The definition is the percentage of someone with a disease that will eventually die from the infection. Well, the case fatality rate is confirmed cases or confirmed death as a percentage of confirmed cases. The problem with COVID-19 is we don't really know what a confirmed case is. Is it just signs or symptom of the disease and a presumptive diagnosis? Does someone have to have this presumptive diagnosis plus a test? And if the test comes back positive or negative, does that mean they are not a confirmed case or not? So we are sort of evolving when it comes to figuring out exactly what a confirmed case is. At the present time, I think most people are using a confirmed case as someone who has signs or symptoms of disease and or have tested positive. But something else you're probably going to hear a little bit later on is instead of case fatality rate, we talk about infection fatality rate. Now, infection fatality rate is the number of deaths from a disease divided by total number of cases. Now, here the cases doesn't need to be confirmed. So we probably should talk about infection fatality rate rather than case fatality rate. But be it as it may be right now, they're used intermittently, meaning we're using the two concepts to mean the same thing. Two other concepts that you hear a lot about is attack rate and secondary attack rate. Now, attack rate is a number of new cases of disease during a specific time interval as a proportion of population at the start of the time interval. On the other hand, the secondary attack rate, a number of new cases among contact as a proportion of total number of contact, and usually it's within a specific area, such as among a family or in healthcare facility. So what I would like to know is if I am in contact with a specific individual within my family or at a gathering or in a healthcare profession or in a health facility, what is the chance for me getting infected? That's the secondary attack rate. And we hear a lot of numbers being bounced back and forth when it comes to attack rate and secondary attack rate, but I just wanted to give you a background on what they're talking about. Point prevalence is the number of current cases as a ratio of the population at the same point in time, which means it's a snapshot at how many people are infected. It doesn't tell anything about how many will get infected in the future. That would be an incidence rate. But a point prevalence is how many people are infected within a population at this one specific time, a snapshot in time. SARS-CoV-2 is the scientific name of the virus that is causing this pandemic, and SARS stands for the Severe Acute Respiratory Syndrome, and CoV is the coronary virus, and 2 obviously is number 2. SARS-CoV-1 is now usually used to describe the SARS epidemic that occurred in 2003. COVID-19 is a disease that is caused by the virus. It's the same thing if we look at HIV. HIV is human immunodeficiency virus, which would cause a disease, HIVD, meaning HIV disease. So here, COVID-19 is a disease caused by this specific virus. And this virus belongs to coronavirus family, where you have other coronaviruses that have caused these type of outbreaks before, not as severe as this one, but other outbreaks, SARS in 2003, and then you had the Middle Eastern respiratory syndrome in 2012. Zoonotic disease are illnesses that originates from animals and infected humans. So SARS, both SARS and now SARS-CoV-2, are thought to be, and probably are, emanates from bats. MERS, on the other hand, probably emanated from dromedaries in the Middle East. So you can see that there might have different sources when it comes to the reservoir of specific type of coronaviruses in the animal kingdom. And I'm going to talk a little bit more about how these zoonotic diseases go from animals to humans a little bit later. Modes of transmission, how virus spreads from one person to another. And there's something else that we hear batted around right now, is something called the cytokine storm. So the cytokine storm is an overreaction of the immune system, which triggers a more severe inflammatory response. Very young individuals may not have an immune system enough developed to create the cytokine storm, and that could maybe explain why very young individuals, 2-year-old, 3-year-old, 4-year-old, 5-year-old, 10-year-old, whatever, they don't have the severe signs and symptoms of COVID-19 that we see in elderly individuals. On the other hand, young individuals, age group 20 to 40, may have a completely exaggerated, out of control reaction to these type of cytokine storms, and maybe that could explain why young individuals, even if their immune system is okay and they don't have any comorbidities, still develop the severe signs and symptoms of the virus. So we will be able to know more about these cytokine storms as how these cytokine storms, we will probably in the future find out more how these cytokine storms affect the outcome as well as the signs and symptoms of the disease itself. Ventilator, a machine that moves air in and out of the lungs when a patient cannot or having trouble breathing of their own. PPE, personal protective equipment, something obviously we know very much about in dentistry. A mask, gloves, and face shields to keep health workers from being exposed to pathogen. A respirator is a specific type of mask that seals around the mouth and filters out particles from the air before they are being breathed in. An N95 mask, for example, filters out 95% of very small 0.3 micron and larger particles. Now, it's very important to remember that if you use a respirator, it's not enough just to put it over your face. You have to actually be able to fit it so it fits you correctly. Otherwise, you're going to have too many gaps that enables these particles to be able to enter into the oral and nasal cavities. And surgical masks or face masks are loose-fitting masks that don't filter out as many particles as a respirator. Now, these respirators have different names. For instance, in Europe, instead of an N95 and N99 and so on and so forth, they're called filtering face pieces, FFP1 and P1, or FFP2 and P2, and so on and so forth. And each one of these different categories of filtering face pieces represent the capacity of this mask to filter out a certain percentage of particles that are 0.3 micrometers in diameter or larger. So the FFP1 and P1, they can filter out particles at that size, at least 80% of those particles. FFP2 and P2, at least 94%. The N95, 95%. And then we have masks such as N99 and FFP3, P3, and N100 that can filter out even more particles of this size. Another thing we hear about when we talk about testing is reverse transcription polymerase chain reaction testing. And this is a technique that looks for a genetic signature of the virus. So what we are looking for if the virus is present. But the only thing we really know is if the genetic material of the virus is present. It doesn't tell us anything about the viability of the virus itself. So we know that the genetic material in RNA in this case is present, but the reverse transcription polymerase chain reaction, or PCR, will not tell us anything about the viability of the virus itself. Now, antibody test is actually the body's host immune response to a disease by producing antibodies, and through the antibody test we will be able to figure out if there are presence or absence of antibodies. I'm going to talk a little bit more about these antibodies in the future in the next couple of slides, but antibodies takes, depending if it's IgG or IgM, or in case of the right way of doing it, IgM and IgG, it will take up to around a month to develop. SARS peaked around SARS antibody level peaked around 3 months and waned over 3 years. And that's important to know, because if we are looking at antibodies as being protective against the virus, in that case we have to realize that yes, it's not a lifelong immunity that we develop. We do develop some immunity, but it may not last for more than from a couple of months up to a couple of years. Sensitivity is the percentage of individuals with the disease that will test positive for the disease. Specificity, the percentage of individuals without the disease that will test negative when testing for the disease. False negative, individuals with the disease that will test negative for the disease. And false positive, individuals without the disease that yet will test positive for the disease. So when we talk about how good these tests are, we talk about the sensitivity, specificity, how many false negative, false positive are we going to get, and so on and so forth. Today, unfortunately, even with the reverse transcriptase polymerase chain reaction, the false negative rate may be as high as 29 to 30%. I'm going to talk a little bit more about that when we talk about testing a little further on in this presentation. And then there's something else called the positive predictive value, meaning of all the positive results, what percentage or what ratio of those positive results are true positives. And that is called the positive predictive value, or PPV. We hear a lot about confirmed cases, recovered cases, active cases, and fatal cases. It's not an issue really of a morbid fascination or anything like that. Really what we're trying to do is trying to figure out how this pandemic is moving in what direction. This information is very important in order to provide policies and guidelines and recommendations on how we are supposed to behave, and the different type of strategies that we need to implement in order to slow and mitigate the progression of disease. Data to find out confirmed cases, recovered cases, active cases, fatal cases can be found at different websites. And two that I'm using a lot is one from the Johns Hopkins University. It's the first web link you see here, coronavirus.jhu.edu. And another one is the Worldometer, which is another website that gives you up-to-date information about, again, confirmed cases, recovered cases, active cases, and fatal cases occurring all over the world. I mentioned before the flattening of the curve. So what is this? Well, if the healthcare system becomes overwhelmed, the majority of extra death may not be due to coronavirus, but to other common diseases and conditions such as heart attack, strokes, trauma, bleeding, and so on and so forth. If the level of epidemic does not overwhelm the health system and extreme measures have only modest effectiveness, then flattening curve may make things even worse. So instead of being overwhelmed during a short acute phase, we remain overwhelmed for a more protracted case. It means that in the beginning of a pandemic such as this one, we're going to have a peak of number of cases, and then it's going to mitigate. And we talk about flattening the curve, meaning we have reached the number of cases to the capacity of the healthcare system itself. So obviously we can change the capacity of the healthcare system, which would then change the level of flattening of the curve. So the capacity can change determined by the number of doctors, nurses, hospital beds, ICUs, ventilators, so on and so forth. So this is flattening the curve, trying to get to a point where the capacity of the healthcare system can actually take care of patients that are infected and infectious and give them the appropriate care that they are in need of. R0 or R0. If R0 is above 1, each case on average is giving it to at least one other person, and you're going to see growth of the pandemic. If it's less than 1, then a group of infected people are generating less infection. So R0 is the product of the duration, opportunity, transmission probability, and susceptibility. And those 4 variables sometimes are abbreviated as DOTS, DOTS. So if you change any one of these variables, the duration, opportunity, transmission probability, susceptibility, we're obviously going to see either increases or decreases depending on how those variables change. So let me show you a little bit more details what that's all about. So duration is how long someone is infectious. If someone is infectious twice as long, then that's twice as long that they're around to spread infection. Opportunity, that's a measure of how many people you come in contact with for every day you're infectious. With something like the flu, you're not infectious very long, very short duration, but a lot of your interaction could potentially spread the disease. The transmission probability is the measure of the chance that the infection will get across during an interaction. And then the susceptibility, of course, is a measure of the chance that a person at the other end of the interaction will pick up the infection and become infectious themselves. Now, if I look at different diseases such as the flu, the R0 for the flu is 1.2, meaning on average an infected individual will infect another 1.2 individuals. Measles, a highly contagious disease, the R0 is 12 to 18, meaning someone with active measles could actually transmit it to 12 up to 18 other people. The R0 for SARS-CoV-2 is estimated to be around 2 to 3, meaning every infected individual has the potential to spread it to 2-3 more individuals. So how do we look at this growth of the pandemic, or epidemic, pandemic in this case? Well, it goes according to an exponential growth. At the bottom of the slide to your left, you will see a link to a YouTube video, which is excellent, that it describes very well how this whole thing works. And I recommend that you go to this YouTube video to see a little bit more than what I'm going to explain to you here right now. But a lot of the information that I'm going to present to you here comes from that video. So it looks a little bit complicated, but it's not that bad. So N subscript D are the number of cases on a given day. E is the average number of individuals exposed to a contagious individual each day, and P the probability of each such exposure becoming an infection. And you can set this up as a mathematical expression where the change, the delta, the change in the number of cases on a given day equals the product of average number of individuals exposed to a contagious individual each day times the probability that an infection will occur times the number of infected individuals in the community. So E times P times N subscript D will show you the change per day on how many people are going to get infected. And you can set this up for what's going to happen the next day, subscript D plus 1, and then you can actually use this expression and come up with even more complicated, what looks like a more complicated expression, but this is the expression that we're looking for when we're looking at growth rate. So if I take this little part of the expression here, 1 plus E times P, it's very similar to accumulated interest. Think, for example, that you have $100 and you put it in the bank and you get 5% interest. After 1 year, you have $105. The next year, that $105 is going to generate another $5.25, so now you have $110.25. The year after that, the $110.25, you're going to have 5% interest, is going to generate another $5 and approximately 51 more cents. So it's accumulated interest that we're looking at. Here's the same thing. If I look here at the growth rate of a pandemic based on this specific parameter, I can calculate how many people are going to be in the population, if nothing else, if there's no other mitigation, how many people in the population will be infected after a certain amount of days. So the first example that I have here is 1.19 up to the power of 31. The 31 represents 31 days. No mitigation, no intervention, just complete growth of the disease, of the pandemic, times 21,000 were the initial cases. So if that happens, we will have 4.6 million people after 31 days. If we can lower the number of 1.19 to 1.15 after 31 days, we're going to have 1.6 million people. And if I can lower it even further to 1.05 after 31 days, we're going to have only 95,000 people. So you can see, if I can actually lower the average number of individuals exposed to a contagious individual each day, and obviously there's strategies we can do that, and the probability of each exposure becoming infection, wearing a mask, if I can lower those numbers, I can actually slow down and mitigate the progression of disease. And this is being depicted in a graph called logistic curve. At the logistic curve, it starts with an upward trend where we see more and more cases of the pandemic, and it reaches an inflection point, and after the inflection point, we're going to have less and less cases, meaning we have an abatement of the growth of the epidemic. And we can calculate where we are in this curve by looking at what we now call the growth rate, which is changes of new cases in one day and divided by the new cases of the previous day. So let me give you a couple of examples. And again, this example comes from this YouTube video that I recommended for you to look at previously. So if I look at the cases March 3rd, 4th, 5th, 6th, and a day after that, March 7th, so it could be 2 days. And then I look at the changes. So if I look at the highlighted, the bold numbers here, between March 5th and March 6th, we had 3,530 cases. And the next day to the day after, we had 4,059 cases. So if I divide the 4,059 by 3,530, I will get a growth factor of 1.15. Now, it's above 1, which means we still have growth, meaning we are still progression of the epidemic. We haven't reached the inflection point yet because it's above 1. On the other hand, if the changes between March 5th and 6th and March 6th and let's say March 7th is the same, meaning we have 3,530 cases between the first 2 dates and 3,530 cases between the next couple of days, we will have a growth factor of 1. Our growth factor of 1 is where we are in the inflection point, meaning the pandemic is not continuing, but is also not slowing down. So what we want to get to is that we have less people, meaning there are going to be less and less people being infected by looking at the change between how many cases we can see from between each day. So in this case, between March 5th and 6th, there were 3,530 cases. Between March 6th and March 7th, we had the change of 2,824 cases. If we divide 2,824 by 3,430, we will get a growth factor of 0.8. Now 0.8 is less than 1, and therefore we are on the upper trend and the upper phase of this logistic curve, and we are anticipating less and less cases, and hopefully in the end it's sort of going to peter out and stabilize, so we're not going to have any more progression at all. So that's how you calculate the exponential growth of an epidemic. But obviously this is based on that we know how many people are actually infected. Means we need to do more testing. And number 2, we also need to have a better definition of who is actually a case and who is not a case. Now, I mentioned before about zoonotic diseases. So what happens here? Well, we have actually reservoirs of viruses in the wild, among wild animals. And when these wild animals actually get together with other wild animals that they usually don't get together with out in the wild, such as open air markets that we see in this case in China, well, a virus from a bat can infect another animal, such as a pangolin, a civet, a pig, a goose, and now you get a assortment of the virus, and this virus can now be infectious to humans. You can also have direct contact between in this case, the coronavirus from the bat and directly into humans. And here again, humans are not immune. They are very susceptible to these viruses. They become infectious, and now the pandemic is starting in a population that don't have any immunity at all against these type of new viruses. So how is it being spread? Well, we usually hear that it's being spread through aerosols. So what does aerosol mean? It's a suspension in air particles small enough that they remain airborne for a prolonged period of time. But there's a caveat here, and that is we're looking at aerosol as virus within droplets. There are large droplets and there are smaller droplets. Large droplets are usually considered 5 micrometer and above, and those large droplets will not settle in the lower respiratory tract. Smaller droplets that are less than 5 micron or 5 micrometers, they can settle in the lower respiratory tract. And you can also see here on this slide that depending on the size of the droplet, the droplet will keep being suspended in the air for a specific period of time. Large droplets, 100 micrometers or 100 micron, only for 10 seconds. And if you go all the way down to the bottom here, you will see less than 3 microns, which is the size of the virus of the coronavirus. They won't settle for even a couple of hours. Now this has been tested out, and this has been tested out in different laboratory environment. And one of the first articles, or actually was a letter that was published, was a letter to the New England Journal of Medicine that was published on March 17th. The researcher here actually looked and compared the SARS-CoV-2 with SARS-CoV-1 and looked at the plausibility of maybe aerosol and or fomite transmission of this virus. So what did they find? Well, if you go into the appendix, so you can actually find on the internet, you can actually see the exact way of the methodology that they used. The results first was the following. The new coronavirus, meaning the SARS-CoV-2, is viable up to 72 hours after being placed on stainless steel and plastic, 4 hours after being placed on copper, and up to 24 hours after being put on cardboard. It could actually be found in aerosol, remaining viable up to 3 hours. Now, we have to differentiate between viable, meaning we actually have the actual virus there, but the key question obviously is if it's viable and is it also transmittable? That's an answer we don't have. So what methodology did they use and how did they compare these two viruses? Well, what they found was something very interesting. They found that the half-life in aerosol were very, very similar between the COVID-19 and the SARS-CoV-1. And that to me is good news, because the vast majority of transmission of SARS-CoV-1 during the SARS epidemic 2003 was actually transmitted through large droplets, and large and small droplets, and not airborne, meaning free viruses in the air that people could inhale. So that's the good news. But I will show you that COVID-19 may actually behave a little bit different than the SARS-CoV-1 virus. But if I look at the viability in aerosol, they were very, very similar. The problem with looking at these type of transmission from aerosol is that the most of the methodology that has been used and the methodology from where we are getting most of our data were conducted in the 1930s. New data coming out right now, such as you can see here in an article in the Journal of American Medical Association that was published on March 26th of this year, will show you a turbulent gas cloud generated by human sneeze. And as you can see on the slide here, the aerosol generated by this sneeze could actually travel as far as 7 to 8 meters, so 21 to 24 feet. That is much, much further than we thought before, when we looked at maybe 6 feet and that's about it, or 2 meters. Now we know that these type of clouds, sneeze, maybe even coughing, and so on and so forth, can travel much, much further. But again, if they travel further, does it mean that further away we're going to have enough inoculum, we're going to have enough viable and infectious viruses to cause a disease? That's another question where we don't have an answer for so far. But there have been several cases now and several reports where we look at clusters of individuals that don't have signs or symptoms of disease at all, number one. And number two, they have been in settings such as family gatherings and they have actually transmitted the disease. This is an article published in MMWR, which is the publication of the Center for Disease Control and Prevention here in the United States. MMWR stands for Morbidity and Mortality Weekly Report. And here they described 2 family gatherings, a funeral and birthday party, where one infected individual, actually apparently infected 16 other people. The people he infected, they range in age from 5 to 86. And 3 people later who died were all over the age of 60, and all of them had underlying cardiovascular or respiratory medical condition. So that's one report. Here's another report that was actually first reported in the Los Angeles Times on March 29th. And this was a case where you had 60 individuals that gathered together to sing. in a choir. Now, they were very careful at that time. They didn't have any contact with each other when it came to hugging and kissing or even shaking hands. The only contact they had was standing close to each other during the choir and singing. Now, they did that for 2.5 hours, and then they parted. They didn't see each other again. Nearly 3 weeks later, 45 out of these 60 individuals have been diagnosed with COVID-19 or ill with symptoms. At least 3 of them, at this point, March 29, had been hospitalized and 2 had already died. So here's an example that it may be droplets, but maybe it's more than just droplets. We know, for instance, that if we try to measure how much airborne viruses we have, we can get a measure. But the question is it transmissible or not? So in a response to a request from the Office of Science and Technology and Policy, OSTP, Harvey Feinberg, who is the chair of the Standing Committee on Emerging Infectious Diseases and 21st Century Health at the National Academy of Medicine, responded to this request about, is aerosolized COVID-19, is it truly infectious, or do we know, how much do we know about this whole thing? Well, this was his response. Currently available research support the possibility that SARS-CoV-2 could be spread via bioaerosols generated directly by patients' exhalation, breathing. Studies that rely on PCR, polymerase chain reaction, to detect the presence of viral RNA may not represent viable viruses in sufficient amount to produce infection, meaning we can find the genetic material, but we don't know if it is the virus itself and it's viable and transmittable. Nevertheless, the presence of viral RNA in air droplets and aerosol indicates the possibility of viral transmission via these routes. So that's not very good news, but something obviously we need to address in our healthcare profession in dentistry. This is an interesting recent article that looks at respiratory virus shedding and exhaled breath and efficacy of face masks. They could actually detect the virus in 3 out of 10, 30% of the cases, with droplets that were larger than 5 micrometers, but those individuals that were wearing a mask, they couldn't detect any viruses that was generated by exhalation, meaning by breathing. Aerosolized particles that were less than 5 micrometers, now we talk about the size of the coronavirus that we are concerned about, not wearing masks, they found that you could actually measure it in 40% of individuals after exhaling. But those individuals wearing masks, we couldn't detect anyone. Now, this is a small study, but it's a study that shows that mask works probably very well when it comes to someone being infected, not infecting someone else. Our question, though, as a healthcare professional, is does it work the other way as well? Do these masks protect us from actually getting the infection or the virus from an infected individual? Well, this was a study that was published actually in the New York Times, looking at the proximity an individual has in their employment, which is the x-axis here, and they measure that from a range of 0 to 100, and they put on the y-axis the chance of having exposure to disease, and again, range from 0 to 100. The profession with the highest exposure to disease and the highest proximity to others were dental hygienists, with a score of 100 when it comes to exposure to disease and 100 to proximity to others. Oral maxillofacial surgeons, 99 over 99. Dentists, 95 over 99. And dental assistants, 96 over 99. So there's no question about it that we are at the highest risk of any other profession, especially the general type of care that we provide for our patients when we generate aerosol, and we need to be able to know enough about transmission and how to protect ourselves. And hopefully we'll know much more about that in the future. So let me just go back and look at some retrospective studies when it comes to the virus, the pandemic itself. This is a retrospective study from China looking at 72,000 cases, and the confirmed cases here were around 44,000. They looked at the age distribution, the spectrum of disease, case fatality rate, and healthcare professional infected. If I look at the bottom here to your left, healthcare personnel infected, out of 44,672 individuals that had confirmed cases, 1,716, or close to 4%, were healthcare professionals, and close to 15% of those was classified as severe or critical ill individuals, and 5 of those individuals unfortunately died. So there's no question here again that as healthcare professionals we are at high risk of being infected by our patients. It was interesting to see in this study that when it came to infection, both men and women had very similar infection rates, meaning around 50% of men and 50% of women got infected. However, the men fared less well than women. 64% more or less of men had confirmed death, while only 36% of the women. So the question then becomes, are there any other confounding factors here? And one could obviously be, but if you look at confirmed death, you will see a difference between men and women. For instance, out of 63.8% of, but if you look at death as an outcome of this disease, you will see there were many more men than women that died from the disease. And the question is, why is that? Why is that so? Could there be some confounding reasons why this is happening? Well, in China, more men are smokers than women. And could it be that smoking is a confounding variable, meaning individuals that smoke, it didn't change if they got infected or not, but if they got infected, it had a more dire consequence, meaning if you were a smoker, maybe you had a high chance of dying. Again, we don't have enough information to know if that's the case, but it could be a confounding to look at, obviously, in the future. The good news here was that close to 90% of people that got infected actually recovered. And at this point in time where this was published, they had a death rate around 4% and still 9% of active cases. Another good news was that close to 80%, a little bit more than 80% of these individuals had very mild disease. Now that's good and bad. Mild disease meaning, is it so mild that you don't get yourself tested and you don't think it's COVID-19 and you continue to act the way you have done before you had the mild symptoms, and therefore you can infect others. So that's the bad news. The good news is, again, that the individual will feel much better. 14% had severe disease, and we had up to around 5% of individuals that got COVID-19 were critical. Another interesting thing was looking at the fatality rate as a function of age. And what they found here that in 1 in 10 patients age 70 and over died, meaning 10% on average of people over the age of 70 died, and it was a function of how old you were. The older you were, the higher were the chances of dying. Now, this is not 100%. We have now seen cases where individuals that are over 100, 101, 104 years old, that got infected, recovered, and even left the hospital to go back to where they usually live. So it doesn't mean that if you're old and get the disease, you will die. It doesn't mean that the older you are, the higher are the chances. Another interesting characteristic was the fatality rate depending on underlying comorbidities. So 1 in 10 of the patients with cardiovascular disease actually died. 10% of people that had COVID and cardiovascular disease succumbed. 7% of diabetic patients with chronic respiratory disease, 6%, high blood pressure around 6%, and cancer around 5 to 6% as well. So it's interesting here that the specific disease, such as cardiovascular disease, had actually the highest fatality rate. And it could be because of the medications they're taking. It could be because there are other comorbidities as well. Obviously, we don't have enough information about that. A recent study that came out of CDC, again published in MMWR on April 8th, looked at age group and hospitalization, and they found that individuals that were over the age of 85, 17% of those individuals needed hospitalization, 75 to 84, 15 to 16%, 65 to 74-year-old, 12%, and then 7 to 8% of individuals between the age of 50 and 60, and then it dropped very precipitously. But still, individuals in the age group 18 to 49, still 2.5% needed hospitalizations. So what about testing? Is this something that is important? Absolutely. Timely and accurate COVID-19 laboratory testing is an essential part of the management of COVID-19 for slowing down the pandemic, supporting decisions on infection control strategies and patient management at healthcare facilities, and detecting asymptomatic cases that could spread the virus further if not isolated. So we should test suspected cases because it's a vital part in understanding the scale of the outbreak and how it's evolving. Test every suspected case. If they test positive, isolate them and find out who they have been in contact with 2 days before they develop symptoms. And this type of tracing of who they could have infected will then generate more testing of more people that may be infected already. Large-scale testing allows health services to quickly identify who has the disease and arrange for them to receive the care needed, and isolating known cases prevents them from coming in contact with others to slow the rate of transmission. And this is something we maybe in the future can be able to do in our dental offices with our patients. But these tests can fail. There's no question about it. As I mentioned previously, one study showed that the sensitivity even of a PCR test, of this polymerase chain reaction test where we look for the virus itself, may have a false negative rate of around 29%, which means 29 people out of 100 that have the disease is going to come back negative. And the question is, why is that the case? Well, it could be a lot of reasons. So I have listed a couple here. The patient may be in an early stage of disease with a viral load that is too low to be detected. The patient may have no major respiratory symptoms, so there could be a little detectable virus in the patient's throat and nose. There may have been a problem with the sample collection, meaning there was very little sample to test. Now, this is one important issue because we see today that the testing that's being done, we do nasal and pharyngeal swabs. And these swabs is exactly what you need to do, but you need to go down into the oropharynx. And if you don't get deep down enough, you don't get the mucus where the virus actually is located, and you don't get enough sample to test to come back positive. Probably the best place to do it is actually in the lower level of the lungs, but obviously that's not something that we can do on a regular basis or doing it for mass testing of patients. So sample collection is very important, needs to be done correctly, and most probably this could be one of the reasons why we have so many false negatives. It can also be that the amount of the virus is different at anatomical sites, obviously. There could also be poor handling and shipping of samples and test materials. There may be technical issues inherent in the test, for instance, the virus mutation. So the WHO, the World Health Organization, suggests that these issues should be taken into account, and that for some people, tests should be carried out several times. Now, there are a lot of new tests, technology out there. This is a recent test technology that actually Abbott put on the market. This little machine that you see here on the slide weighs around 3 kilo or 6.6 pounds, and it can actually test up to 50,000 tests per day. And this is an RCT PCR test, meaning you look for the genetic material. It takes around 5 minutes to get a positive test and up to around 13 to 14 minutes if the test is negative. Now, this is not the only device and technology out there. There's a lot of different type of devices, technology coming very, very soon to the market, and you should look for them. But be careful. Try to find out what the sensitivity and specificity are of these tests, how they can be used. Can they be used as point of care? Can they be used in a dental setting? Can they be used only in a hospital setting? And even more importantly, what do they actually measure? Do they measure the virus itself? Do they measure the antibodies? And so on and so forth. Well, the antibody tests are also becoming available. Antibody testing is multi-purpose. It can verify that vaccines are working as intended during clinical trials or be used in contact tracing weeks or longer after suspected infection in an individual. Probably the most important current use is en masse, is to help inform public policymakers how many asymptomatic cases have occurred in the population. And antibodies reveal obviously evidence of a previous infection any time from about a week after infection occurring. As I mentioned previously, antibodies to SARS-CoV-1 peaked around 3 months and then waned over the next 3 years. So it's important also to figure out when we can start to see these antibodies. For instance, if someone got infected, they may not have the antibodies for the first week, So even if we test, it can come back negative. So it depends on the body's ability to produce these antibodies, and that could be individualized. Every patient may not be the same. So questions and answers. Well, there are a lot of very good sources here, and I just mentioned a couple. And maybe what you can do is you can stop the presentation at these points in time and put down or jot down some of the links here that you can use. Center for Disease Control and Prevention, CDC, they have a specific site about the coronavirus, and they also have the publication, the MMWR, and they have a specific site for all of those publications, or MMWR, that deal with coronaviruses. You also have the European Center for Disease Prevention and Control. You have the World Health Organization, and then you have other sites that are associated with the National Academy of Medicine, such as the National Academy or Academy's Press. And this is a very interesting site because many of the questions that are posed to the National Academy then poses to specific committees that then give an answer. For instance, as I mentioned to you previously, for instance, is the virus aerosolized and can it be transmitted that way? They also have answer to the efficacy of face masks and so on and so forth. And every day they're coming up, almost every day, they're coming up with more answers to these questions that are being posed to them. So this is a very good site to get very updated information by good scientists. You can also look at the epidemiology of this virus from different sites. Our World in Data, Johns Hopkins University I mentioned previously, the Worldometer as well, and I just added one other site here, the Institute for Health Metrics and Evaluation. I think they're out of Washington, the state of Washington. They're actually looking at different matrices or matrices on how to are looking at different matrices and how to they're looking at different projection through different type of matrices that are available to you if you want to use them as well. Also, a lot of the major medical journals, namely Journal of Medicine, British Medical Journal, the Journal of the American Medical Association, the Lancet, Science, and many others, they have specific sites also for coronavirus. And today they are open access. All the information about coronavirus published almost anywhere is now open access. And this has been an agreement between the bigger publishers in the world that all this information should be available to anyone. It doesn't mean that you cannot get it if you don't have a subscription. Yes, with a subscription, without a subscription to a specific journal, you should have availability to get all this information. So Elsevier, Wiley, Sage, and the two last one I have put up here, the Copyright Clearance Center, is a very, very good link to resources where not only you get access to these publishers and their publications, but you also get access to publications coming out of different centers and focus groups and so on and so forth. So it's a very good site. The last one here, the Lit COVID, it's something put together by the National Library of Medicine. And here, this is a repository of all the articles published on the coronavirus. And this is amazing if I look at how many of these articles are available right now. If I look on average between January 20th until today, you have 3,368 articles. It comes out to approximately one article every half an hour. Now, if I look at the last week or so, you probably have an article out there every 15 to 20 minutes, even faster than that. And that is a problem. And the problem with that is that there are very few peer reviewers out there. Many of these articles are posted very quickly on different sites, such as this one, medRxiv. And here you can post pre-printed articles, meaning these articles have not been accepted yet for publications and they haven't been published yet. Usually you would only post things on these archives after peer review. But now, because of the coronavirus, because the need to get all this information, now many articles being posted without peer review. So obviously there are a lot of information on these archives, such as medRxiv here. Many articles here may not be reliable because of lack of scientific rigor. And this is very important. So when is a person not infectious? Meaning, is someone infected? When is this person not infectious any longer or contagious any longer? The patient is free from fever without the use of fever-reducing medications. The patient is no longer showing symptoms, including cough, and the patient had tested negative on at least 2 consecutive respiratory specimens collected at least 24 hours apart. Now, these recommendations may obviously change. Is it safe to use non-steroidal anti-inflammatory drugs? Well, the question is coming up because the severe acute respiratory syndrome of these coronaviruses, such as COVID and COVID-2, they bind through the angiotensin converting enzyme 2 system, the ACE2 system. So the NSAIDs are known, theoretically at least, to increase or upregulate those ACE2 receptors. So if you take NSAIDs, does that mean that now you have a higher risk if you have been exposed that you get infected? And there are no data. There are some very, very preliminary data that show that it might be, but these again are studies that are not scientifically robust enough to base your recommendations on. In the United States, at least, we say that yes, you can use NSAIDs. However, if you want to be prudent, you should probably keep yourself to using naproxen sodium ibuprofen. In France and UK, there's a recommendation not to use NSAIDs. So depending on where you live, depending on the recommendations, you should follow the recommendation, whatever jurisdiction you live in. Are there any ongoing trials to treat COVID-19? Yes, there are several trials out there, and there are numerous drugs being identified right now as potential to treat COVID-19. One large trial that was launched by WHO, called the Solidarity Trial, was launched on March 22nd, looked at a combination of 4 different types of medications. One drug combo were medications that are usually used for HIV. There was also malaria treatment, first tested during the World War II, hydroxychloroquine, and a new antiviral whose promise against Ebola didn't work out very well. And this is common. When you get the new pandemic, you take a lot of different medications that may have theoretically or plausibly be able to be used against this specific virus, and you try all of them out. Something that is probably most promising are actually looking at monoclonal antibodies, meaning getting antibodies from individuals that are convalescent, and these antibodies, if we could actually purify them and we can then use them as passive immunity or even treatment on people that are infected, or we can actually try to replicate them in a way that the body would think that they are the natural antibodies, and then we can prevent maybe the viral attachment, endocytosis, translation, proteolysis, or even RNA replication. So we will know much more about this in the coming days and weeks, obviously. But what about facts in quotation marks, meaning things that we hear out there that are not correct? SARS-CoV-2 cannot be transmitted in areas with hot and humid climates because heat and humidity will kill the virus. The same thing occurs in cold weather. Well, there's no absolute no's here because the humidity may actually affect the transmissibility of the virus. It doesn't mean that it cannot be transmitted. Yes, of course it can be transmitted. And we look at the flu, well, we shouldn't compare this pandemic with flu pandemics, but if you look at the flu pandemics over the past 250 years, the weather had very little impact on the transmissibility of the virus itself. Taking a hot bath prevents COVID-19? No, it doesn't. SARS-CoV-2 can be transmitted through mosquito bites? No, it cannot. Hand dryers are effective in killing SARS-CoV-2? No, that has not been shown that they are effective in killing this virus. Spraying alcohol or chlorine all over your body will kill SARS-CoV-2? No, there's no evidence for that. Vaccines against other viruses such as pneumococcal vaccine or Haemophilus influenza vaccine can provide protection against this new coronavirus? No, there's no evidence for that either. There's evidence that regularly rinsing the nose with saline has protected people from infection with the new coronavirus. No, there's no information about that either. There's no robust scientific information that would promote this type of behavior. Antibiotics should be used as a means of prevention or treatment of COVID. Well, antibiotic may be used for super infection by bacteria, but as you know, antibiotics don't work against viruses. So maybe antibiotic could be used for comorbidities or co-infections, but not to treat the virus itself. There are already specific medicines recommended to prevent or treat COVID-19. No, as of today, April 8th, there are none. Nor is there a vaccine available today, but hopefully in the future we will have both treatment and vaccines. There's evidence from current outbreak that eating garlic has protected people from this virus. No, there's no such evidence. You can protect yourself from this virus by swallowing or gargling with bleach, taking acetic acid or steroids or herbs, or using essential oils, salt water, ethanol, or other substances. No, there's no evidence for that either. And this virus was deliberately created or released by people? No, there's no evidence for that whatsoever. On the contrary, there's very strong evidence that this is a zoonotic disease starting from the coronavirus that are carried by bats. And ordering or buying products shipped from China will make a person sick. Well, a lot of this information is coming from all of these websites that promulgate false coronavirus information. And this is just a short list of these websites that you find in the United States. And they grow. They grow exponentially, these websites, unfortunately, and they promote this type of conspiracy or conspiracy ideation that is very, very detrimental when it comes to be able to get the right information and the good information in order to figure out how to deal with this pandemic. These websites also, you can find these websites also in France, in Italy, in Germany, and United Kingdom. What about dentistry? Well, I put up 4 things here. One is aerosol, obviously. We need to figure out ways to reduce the type of care and procedures that generate aerosol. And we also have to figure out if aerosol can actually transmit a disease. Is it transmittable or not? When it comes to PPEs, usually we talk about universal precaution. Well, that is bloodborne diseases. And now maybe we have to expand that to include airborne diseases as well, obviously. And this can be done different ways. So maybe instead of a regular mask, we use now N95. But don't forget, if you use the N95 mask, they have to be fitted to you. Otherwise, they're not going to work very well. There could be new types of engineering controls, negative pressured rooms, ultraviolet light. Don't forget the waiting rooms, though. This doesn't have to be transmitted. This virus could possibly also be transmitted, as I showed you, even in situations where people only talk to each other or have social daily contact with each other. So don't only look at your operatories, look at the waiting rooms as well. At the present time, there are many jurisdictions that promotes limiting the care to patients, only urgent and emergency care, and I'm going to show you a little bit later the definitions between the two. Teledentistry may be coming more in the future, and there we have to look at the technology available today and the technology in the future, obviously, as well as concerns about privacy and other issues. The scope of practice, maybe in the future we will be able to actually provide immunization and vaccinations for our patients. And maybe we can use the dental clinic for non-dental purposes. I mentioned before testing and tracking of patients and so on and so forth. And this is just a very short list. There are many, many more things that may actually change dentistry from the way we knew it. Don't forget that when the HIV epidemic came around, many people said that, it's impossible to treat these patients. We started to change infection control procedures. We started to get standard precautions, then universal precautions. And now today, we don't see any problem, but it changed the way we practice dentistry. The same thing's going to happen with this airborne disease, that it might actually change dentistry as we know it. Now, there are a lot of information about infection control, and I'm not going to be into details about it. I'm just going to give you one website here, and that is CDC, the Center for Disease Control and Prevention, and they update their recommendation in a timely manner. For instance, this update came April 7th, where they had some small changes in infection control recommendations for dental settings specifically. So go and look at these websites from time to time, and you'll be able to see that there are changes. There are also National Dental Association that provide some guidance. This is from the American Dental Association. They have a very good website specifically for coronavirus. So what is needed and what do we need to do? Identify individuals, signs, symptoms, testing, rigorous contact tracing in order to find individuals that infected individuals have been in contact with in order to isolate them and in order to figure out who they have been in contact with. We have to isolate those individuals that we know are infected and quarantine individuals that might have been exposed and may be potentially infected. Social distancing seems to be working very well in those areas that that type of strategy has been implemented. We do see its effect. Travel restrictions, hopefully they will ease up in the near future, but at the present time they're both domestic and international travel restrictions in place. The lockdown, it's estimated that probably half the population in the world today is under lockdown, more than 4 billion people. mass-produce personal protective equipment, retrofit hospitals so we have adequate number of ICUs and ventilators and other type of materials and equipment that we need specifically for these patients. We have to maybe prioritize treatment, and here again in dentistry, now we prioritize urgent and emergency care versus elective care. Focus on the development of therapeutic and preventive medications. But probably the best advice I can give you is let the expert do the talking, especially when it comes to medical claims not supported by solid evidence. So listen to the expert, try not to listen to the non-experts, and you will be able to make your own decisions about what the true and robust science is. So thank you for your attention. I hope this was helpful, and I hope that you will be able to use some of this information in order to treat your patients both appropriately and in a safe manner, as well as become a very good resource to your patients. Thank you very much.